Hello, and welcome to the Colorectal Cancer Prevention and Early Detection webinar. Thank you for making your health a priority and joining us this evening. My name is Natalie Evans, and I will be your host on behalf of Franciscan Health. I'm excited you are participating in this installment of our health education webinar series. Following this presentation, you will better understand what is the colon and rectum, why is screening important, what are my screening options, who is eligible to be screened, who is at the highest risk, how can I schedule an appointment? But before we begin, I'd like to share a few housekeeping items. Everyone is muted upon entering the virtual event. We ask that you keep yourself muted to help us avoid background noise and interruption. If you have questions to ask the presenter during the presentation, please enter them in the chat window. We will address those questions after the presentation. Our awesome administrator, Kirsten, is taking care of everything on the back end. So if you experience any technical issues, just type them into the chat window to be resolved. If you miss anything, don't worry. We will send out the on-demand recording in a follow-up email. If you are ready to schedule an appointment with one of our colorectal specialists following the presentation, please let us know in the chat and you will receive priority scheduling. Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. It is truly my honor to introduce you to the expert who will present tonight's session. You will hear from Dr. Evan Fitz, colon and rectal surgeon with Franciscan Physician Network, Indiana colon and rectal specialist, as he discusses the importance of getting screened and how early detection saves lives. Franciscan Health is the first and only hospital in Indiana to earn an accreditation from the National Accreditation Program for Rectal Cancer, a quality program of the American College of Surgeons. Our colon and rectal specialists are experts in the diagnosis and treatment of diseases in the colon, rectum, and anus. We'd like to test your knowledge before we get started. Let's start with a quick poll question. When is Colorectal Cancer Awareness Month? A, March, B, May, C, July. It looks like 83% of you chose March, 17% chose May, and no one chose July. I'm glad to see that most everyone is engaged. Now, without further ado, please welcome Dr. Evan Fitz as he explains what you should know about colorectal cancer screening and which treatment options are available.
Thank you, Natalie, and welcome, guys. Thank you for being present for tonight's webinar. We thought that it was an appropriate time to do it because, as you now know, March is Colon and Rectal Cancer Awareness Month, where I'll talk a little bit more in the presentation, but we really want to make sure that we get the word out, because by getting the word out, we really can prevent colon cancer. So I'll start off with just a couple of brief facts and things that to get us all on the same page. And a lot of times people ask, well, what is this? And so this is your colon and your rectum. We'll go back one. And the colon is also known as the large intestine. So the rectum, a lot of people think it's something separate, and it technically is, but really the rectum is just a part of your colon or another part of the large intestine. Now, why is this important to know? It's important to know this because cancer can and will develop in any part of the colon or rectum. So being able to look at the entire thing is important. Speaking of, is colon cancer preventable? Well, the whole purpose of this presentation and the whole purpose of us being able to do screening is because, yes, in most cases, it is preventable. So why is screening in and of itself so important? Well, screening is important because it's necessary for prevention and not only preventing colon cancer, but detecting it early when we can actually do something about it before it gets too late. Everyone always asked what was my favorite planet growing up as a future colon and rectal surgeon. I always knew. So speaking of screening, it gets a little confusing. Everyone thinks colonoscopy, and I'll tell you later, that's my biased favorite, but there are options. There are things like fecal occult blood tests. If you've ever given a stool sample on a card, that's not incorrect as long as you follow that up with a mini scope every 5 years. You can get a radiology contrast enema every 5 to 10 years with another fecal occult blood test. You can get a colonoscopy every 10 years, which is pretty attractive, only having to do it 3. And Cologuard, which we'll talk about, every 3 years. Now, the reason one of these may be better than the other is that most insurance plans cover screening 100%. But if you have a screening test that's positive and you need something else like another colonoscopy to confirm, then insurance doesn't always pay for that. And sometimes you end up getting stuck with the bill.
All right, we've had some great information so far. Before we move on to our next section, it's time for another poll question. Are colonoscopies required when you don't have a family history? Yes or no? It looks like all of you agreed that it is very important to still get your colonoscopy. So thank you for being engaged. Back to you, Dr. Fitz.
Thanks, Natalie. And yes, that's true. So it's important. Screening is for everybody. And we'll talk a little bit of how things have changed. Everyone used to remember the age of 50 years old, but this is important that screening is now for all people at 45 years old at the latest. And this gets a little, complex, but really if you can just remember 45 years old instead of 50, you'll be on the right track. So nowadays, I get a lot of questions about Cologuard. Cologuard, you'll turn on the news, you see ads and you see it and everyone thinks it's great. It does have some benefits. What Cologuard is an at-home stool sample test that people send in a stool sample, and it targets the DNA, and it's trying to look for the DNA changes that go from polyps to cancer. Now, there are benefits to Cologuard. I think the obvious one that most people like is the fact that they don't have to do a prep and they can just do it at home. And it is better than no testing, but it's probably not cost effective. And the reason that is because it has a false positive rate of around 13 to 20%, which means 13 to 20% of people that have a positive are still going to get a colonoscopy and there actually wasn't anything there in the first place. The main reason I'm not a huge fan of Cologuard in general is that on the whole, the average American has about an 8% chance of having colon cancer at some point in their life. And Cologuard is really a test to look for cancer. It's not really a good test to look for polyps. Polyps can turn into cancer, and with Cologuard, 50% of polyps that are high risk can be missed by Cologuard. So while it does a good job of catching cancer, it doesn't do a great job of catching polyps before they turn into a cancer. So for all of those reasons, it's better than nothing. And certainly if somebody wants to get the Cologuard, I would never say no, but there are some things to consider, and that colonoscopy is not something that we just sort of forget about now that we have some new technology. So I've talked a little bit about high risk and what that means. Well, there are people that are high risk that should get colonoscopy screenings before they're 45. And there are certain things you can't control. There are hereditary disorders. There's things like Lynch syndrome or familial adenomatous polyposis that people can be born with that precludes them from having or predisposes them to having risk. The most important that most people need to know about is a family history, especially a first-degree relative. So if your mother or father or brother or sister developed colon cancer or had a lot of polyps, especially at a young age, below the age of 60, that is something that we really want to know because that may mean you need your screening even earlier. And other things like Crohn's disease and ulcerative colitis. So those are things you can't control. But what about things you can control? Well, things that probably you would get on a multiple choice test, you can guess. Weight increases your risk of developing colon cancer. So a BMI greater than 30 greatly increases your risk. The American diet, where we eat a lot of processed meats, a lot of red meat, those all put us at increased risk of developing colon cancer. Smoking. Smoking doesn't just affect the lungs or the heart. Smoking also greatly affects the risk of developing colon cancer. Heavy alcohol use and decreased exercise also increase your risks. So if you can lose weight, start exercising, stop smoking, eat healthier, not only are you going to just feel better and, overall, have good effects on your lungs, your heart, your skin, basically everything, you're also going to decrease your risk of developing colon cancer, which is something that's important. I think this is a good slide because it not only talks about 45 at the end, but I think the most important thing is once you reach the age of 35, ask your doctor. Put the burden on them to figure out when you should get screened, just so you don't miss it. Because if you have a relative that was diagnosed with colon cancer at the age of 38, well, you should probably 48, then you should probably be getting your scopes around 35 or 38, not the age of 45. So basically, almost no age is too young to at least ask. Well, we look for screening. We do colonoscopies, we do Cologuard, we do all these tests because we're trying to find colon cancer before it ever has symptoms. But what if you do have symptoms? Can colon cancer have them? And the answer is yes. Some of those symptoms can be rectal bleeding, blood in the stool or blood in the toilet after having a bowel movement, a persistent change in your bowel habits, including really persistent diarrhea, constipation, pencil-thin stools, cramping or pain in the lower stomach, unintentional weight loss, losing 20, 30 pounds, and you're not really trying to, with fatigue and anemia. Now, it's not to say that all of these mean you have colon cancer. So it could be something as simple as hemorrhoids. It could be something as simple as you ate something funny. But if you have any of these symptoms and they're persistent, I would certainly recommend that you follow up with your primary care practitioner or a colon and rectal specialist or a gastroenterologist to get evaluated to make sure that nothing's getting missed. One question I get, and I think this actually scares a lot of people, and it scares people from getting screened, is they always ask, well, if I get cancer or if you find something in that colonoscopy, does that mean I'm going to have an ostomy bag? And the answer is no. Getting colon cancer or having polyps does not necessarily mean you'll have an ostomy. And in fact, there are a lot of ways that we can prevent it. And the whole idea of getting screening is to find things early before they get so advanced to where we would need to use a step like that. So why is screening important? Well, screening is important because it actually saves lives. Not only are we finding cancers early, are we finding polyps early, but we're actually decreasing the chances of colon and rectal cancer mortality. And over the past 25 years, this has decreased, which is an extremely important thing. And perhaps the only reason that's been able to happen is because we've been doing a better job about raising public awareness. Public awareness is important because we can't screen you if you don't know why you're getting screened or if you aren't amenable to allowing yourself to be screened. So getting into the minds of the public is major. And one thing that's been a big push over the past 10 to 20 years that I'm a big fan of is getting celebrities involved. Katie Couric talked about her colonoscopy. Dr. Oz did it while he was completely awake, which was amazing. And actually Ronald Reagan talked about getting colon cancer. And so the most amazing thing is that this destigmatizes it. For whatever reason, people just don't want to talk about it. They think that it's weird, even though everybody's read the book as a child that everyone poops. For whatever reason, when it comes to colonoscopies and dealing with colon cancer, people get worried about it. The other thing that people get worried about is they're worried about the prep and doing a colonoscopy. And I'm here to tell you, it's not that bad. A colonoscopy is really just one day of prep. The day before, you do a clear liquid diet, and then that evening you start the prep, and that's basically to clean you out so we can actually see and we don't miss anything. So really it takes one day off of work, which is the day you're getting the scope, but you can prep the day before. We always make sure that you're sedated and comfortable during a scope. Unless you for some reason don't want to have any medicines, you will always make sure that you're sedated and comfortable. And you get to eat regular food afterwards. So you get your scope in the morning and you go eat a healthy breakfast and have a great time. And overall, even though it's a procedure, it's a very well-tolerated procedure, and it's much better than a late diagnosis that could have an increased chance of an invasive surgery or an ostomy bag. So overall, how are we doing? Well, Indiana right now is at about 68% of our people are getting screening at the appropriate time, which is great, but not necessarily meaning we're at our goal. So in the 1990s, we were only at about 20%. Now, overall, America's at 65%, so much better, but we're really trying to get 80%, and the ultimate goal is 100% to do whatever we can. So we're fighting colon cancer, we're fighting rectal cancer. Well, are we winning? Well, the answer is a little complicated. You may have seen studies in the news that are talking about younger patients getting colon cancer, younger patients are getting rectal cancer, and that is worrisome. And it's actually caused us to change some of our recommendations. In fact, the New York Times talked about this, and they talked about a patient who got colon cancer at 22. And she said, I still remember getting the phone call from the doctor. And he said, I'd never have guessed that a 22-year-old would have cancer. And while that is rare, it's actually not as rare as we want it to be. There was a paper that actually looked at patterns of colon cancer in the United States over the past 30 years. And it showed that overall, we're getting better at colon cancer incidence. It actually decreased 3% per year. And it decreased in patients who are about 50 to 60 years or older. And that decreased because we're getting better about risk factor changes, and we're getting better about doing screening. Like we said, the 20% in the 1990s, and now we're at the 65%. But we'll go one more. But unfortunately, not everybody is seeing that improvement. And it's mostly that colon and rectal cancer incidence increased for those in their 20s and 40s. So if you were born in the 1970s or the 1980s, you had a similar risk for those born in 1890, which is terrible. And this is even stronger for rectal cancer, in that nearly 30% of all rectal cancer that was diagnosed in patients less than 55 years old. And in 1989, that was 15%. So one question is, what in the world is behind this trend? Well, unfortunately, it's similar to some of the things that we know. It's younger and younger people. We have more of the low fiber Western diet. We live a sedentary lifestyle. We're having more and more processed foods from younger ages, and we have excess body weight. So while alcohol and cigarette use are decreasing among younger people, some of the other risk factors, such as the body weight, the poor diet, and the sedentary lifestyle, are actually causing it to be increased, which is something that is really concerning to us. The other thing that's concerning to us is that young patients are 58% more likely to be diagnosed with advanced rectal cancer, meaning rectal cancer that has symptoms and will probably need more treatment than just a simple colonoscopy or even a 1-2 day operation type thing. And that's partially because it's not on our radar. You know, when you're 24 years old, you have some bleeding, you ignore it. You're 24 years old, you lose some weight and you just think, oh, that's fine, I just haven't been eating it. And you're 3 times less likely to be insured. So all of these sort of contribute to colon cancer being more advanced when it is diagnosed in a younger person. And colon was always upset that it wasn't number 1.
All right. We've already received a lot of great information, so let's take a brain break and do another poll question. Is it time to change screening guidelines? Yes or no? It looks like 86% of you said yes and 14% said no. Let's see the real answer. Thanks for participating.
So the answer, this is kind of a trick question because the answer is yes, because I gave it away a little bit earlier in the talk where I talked about how the age changed from 50 to 45, but that actually happened in October. So I guess I could say it's already changed, but really it is time to change the guidelines. And what I mean by that is time to change the guidelines to age 45. So the USPSTF and the ACS, which is the American College of Surgeons, and the ASCRS, which is the American Society of Colorectal Surgeons, all of us agree that we want to change the screening for normal risk people to age 45. Now, you wouldn't be surprised to know that unfortunately not all insurance companies agree, because that means they're going to have to start paying for colonoscopies for younger people. But luckily, in the new General Assembly of Indiana in 2020, they required insurance companies to cover colonoscopies at age 45 instead of the previously recommended 50. So if you go to your doc, you should say, hey, I'm 46 years old. Should I get my colonoscopy? And the answer is yes, and they will be happy to refer you. So I've given you a lot of information. There's a lot of changing things with the research. So just what are we supposed to do? And the answer is common sense, common sense, common sense. Don't ignore symptoms. If you will know your body better than anybody. So if you notice something's different in your body, listen to yourself, bring it up with your physician. Know that age 45 is for all, and we really want to encourage healthy lifestyles, smoking cessation, exercise regimens. Our screening guidelines of age 45 won't get everyone. There are younger people that will slip through the cracks, but if those patients know the warning signs, know about anemia, know about bleeding, know about cramping and losing weight, then we're more likely to find them earlier where we can treat them earlier and have a better outcome.
All right, it's time for our final question of the evening. Thanks for your undivided attention and willingness to participate. Let's see what you've learned. Which ethnic group is at the highest risk for colorectal cancer? A, African American, B, Hispanic, C, Caucasian, or D, other? I look forward to your answers. All of you chose African American. Very good. So back to you, Dr. Fitz.
Thanks. Yeah, and unfortunately that is true. So African Americans are an increased risk. They're 20% more likely to get cancer and 40% more likely to die from it than other racial and ethnic groups. And actually, the screening guidelines used to be 50 for white people, Hispanic, and other ethnic groups, and 45 for African Americans. And now we're changing it to 45. So the question I've gotten was, will that mean age 40 for African Americans? Well, they haven't said that yet, but there are talks that may be something in the works, but not yet officially. So like we said, March is Colorectal Cancer Awareness Month. We really wanted to do this webinar because we think that's important to us. We just recently got a national certification by the American College of Surgeons, and that we are the only center in Indiana that's actually a rectal cancer center of excellence. This is something that we truly believe in, and that we think that by being aggressive and treating patients, we can add years to the life of our patients and cure them from cancer and give them better overall outcomes. And so, but all of that starts with you and being aware of the things that can happen. So I appreciate your attention, and I think there will probably be questions, and I'll let Natalie take it from here.
Yes, now I want to take the rest of the time to answer some of the questions that came up during the presentation. I saw your hands raised, so we look forward to it. So. Well, it looks like Tom asked, if screening works, why aren't more people doing it?
That's a good question. I think everybody has their own reasons. I think I talked a little bit about that. And one of it is, I think people have heard horror stories about colonoscopies. That's a big part of it. They just sort of they heard from their aunt or their sister, oh, that prep was terrible, or I was awake during it. And that scares them. Another thing is that people are scared of what they might find. They just don't want to know. And that certainly can play a part in it. Unfortunately, being uninsured can contribute to that. And I think just certainly there's a sense of, as humans, sometimes we like to live in denial and say, well, that'll never happen to me. And so we sort of just kind of put our head in the sand and unfortunately sometimes ignore things. And so while we're up to 65 or 68% in Indiana getting screened, those 32% that aren't have their own reasons. But I think as we do our job to try to educate people, that'll only get better.
All right. Don't be shy, guys. It looks like Ashley here is asking, why remove polyps when you don't have cancer? Can they develop into cancer?
The answer that's a great question. The answer is yes, that's the whole idea. So the chances that a single polyp will ever develop into a colon cancer are somewhere around the range of 1%. But about 98% of cancers started out as a polyp. So we don't know which of that 1% of polyps is ever going to turn into a cancer. So we go ahead and we take them out at the time of the colonoscopy to help prevent them ever from becoming a cancer.
All right. It looks like Henrietta is asking, since African Americans are the ones who are most likely to get it, it is no doubt due to our diet. So what types of foods should we be eating? Should we not be eating? Excuse me.
So that's a great question. I think one of the strongest foods that has a risk factor with developing colon cancer is actually the percentage of red meat in the diet. Americans get colon cancer a lot higher than people from other nations that don't eat a lot of red meat, that eat more fish. So probably I would recommend, certainly I eat steak, I love it. I just wouldn't have it every night. Don't eat the hamburgers every night. Add in a lot more fish, a lot more chicken, less sausage, anything that's processed like hot dogs and sausages and things that are smoked. All the things that kind of taste good should be more of like a once in a while treat and not the every night diet. So the answer is processed foods. But if you had to pick one, it would be red meat is really at the top of the list.
All right. It looks like Randy is asking, what lifestyle changes can a person make to prevent colorectal cancer?
So lifestyle changes, the first thing I would say is becoming more active. Whatever it is, even if you already are on some sort of exercise regimen, just continuing with that, make sure that you walk, take the stairs. If you're smoking, do everything you can to either quit smoking or decrease, limit alcohol intake. So, a glass of red wine a night is not going to hurt you, but 3 glasses every night probably will. Things like that where you're, not having as many processed carbohydrates, where you're actually eating salads, high fiber diet. So if you're going to get bread, don't get the white bread, get the whole grain, whole wheat bread that has more fiber intake, more fruits and vegetables. All of those things in terms of the diet, decreasing smoking, decreasing alcohol, and increasing your activity level will only help you.
All right. Eric asked, can you please explain the process of the actual colonoscopy, not the prep, and the time it takes to perform one?
Sure. Sorry, I was muted. So when you come in for a colonoscopy that morning, if we didn't already meet, we'll talk about it. When you go for your colonoscopy, you'll have done your prep, so I won't talk about that. You'll come back and usually an anesthesiologist will sedate you so you're asleep. You'll be comfortable. You'll be in kind of a dark room where there's a nurse around and the anesthesiologist and myself. And during the colonoscopy, what we do is we first start with a digital rectal examination where we feel just to make sure everything looks normal or feels normal on the inside. And then the scope is around 4 feet long, 5 feet long, and slowly but surely we insert it into the colon, and it goes all the way through that large intestine, that anatomy that I looked at the beginning. And then once I get to the end, I start to pull it back and I slowly get a 360-degree view all inside the colon, looking at it, making sure everything looks normal. If I see anything that looks weird, if I see a polyp, I remove it or I'll biopsy it. And then after that, it's done. It usually takes somewhere in the range of 15 to 20 minutes. Afterwards, you wake up, we give you something to drink, and then you get to go home and eat and carry on with your day. After that, we tell you whether you need to have a colonoscopy in 10 years because everything was great, or 5 years if we saw a couple of polyps and we maybe just want to keep a little bit of a closer eye on you, or we'll call you with the biopsy results. So that's in general the thing. It takes, you'll be in the surgery center or wherever the endoscopy center, overall, probably about an hour and a half of just getting checked in, getting the colonoscopy and out the door. So it's a pretty nice process.
Thank you, Dr. Fitz. It looks like Cindy asked, why does the type of polyp matter? Please explain what to look for as a patient.
So the type of polyp matters because certain polyps are higher risk than others. And there's nothing that you need to look for because you can't look in your own colon, so you wouldn't know what type of polyp you have. That job is on us to be able to find the polyps and tell you exactly what's wrong with them. Now, I guess the basic thing I would say is that the bigger the polyp, the more worrisome it is. So we use, I would say 1 centimeter is kind of, or basically a little under half an inch is our cutoff for what we would consider a high risk polyp. And that may prompt, if you had a 1 centimeter polyp, it may prompt me to say, you know, maybe let's do another scope in 1 year or 3 years and keep a really close eye on you just to make sure that we're not letting anything get out of hand or get too advanced for us.
All right. Don't be shy. Let's see. It looks like Susan asked, what should I do if I can't afford to pay for a screening test or the cost associated with the screening?
So that's a great question. So most insurance plans will cover screening completely 100%. They found that it's actually a lot cheaper for them to cover screening and as opposed to waiting for things to get too advanced. Now, if you can't, the financial planners or the social workers or the nurses at any of our offices with St. Francis, when you contact them, will work with you because our main goal is not to really profit off this. Our main goal is to try to decrease the rates of cancer and decrease the rates of advanced polyps and make sure that we find those. And so we are very, very flexible in doing whatever we can to make sure that you get screened.
All right. Terry asked, what does the future of colorectal cancer research look like?
I would say it's probably going to be a lot of immunotherapy. You may have heard that before. I think that's sort of a new offset of chemotherapy where they're using gene tailoring and your own immune system to fight colon cancer sort of at a molecular level. So things aren't quite so toxic when it comes to chemotherapy and all of that. So I think that is going to be the future of it, is really being able to better treat and target colon and rectal cancers with our own body's immune system.
I know I saw some hands during the presentation. Feel free to ask your questions. Please remember to type your questions in the chat box. I see some hands raised, so please type in the chat box and we'll get to you as quickly as possible. All right, we got one. Let's see. Hi, Mike. Mike asked, if you remove polyps, what is the difference in recovery?
That's a great question. The answer in general is no difference. Polyps are tiny. In general, they're usually around 5 millimeters. So if I take a polyp out versus I don't take a polyp out, there's almost never a difference in that patient's recovery. Now, you sometimes, I would say about 1% of the time, somebody might have a little bit of bleeding afterwards, after the colonoscopy. I always tell them to watch that, but 99% of those patients, it's very self-limited. It happens once or twice and then it goes away. Very, very rarely is there a serious complication of a colonoscopy. And if I take a polyp out, the chances that you'll have a normal recovery is basically the same as if I didn't.
All right. Janelle asked, do you need a referral from your primary doctor to be screened?
No, not as far as I'm concerned. Call my office and say you're 45 and we'll get you set up.
All right. Wanda asked, is having a microscopic colitis risk for colon cancer?
That's a great question. The answer is no. Microscopic colitis is, I guess, a disease, a condition that can cause cramping and diarrhea and changes in the bowels, but it actually doesn't have a risk for an increased risk for colon cancer, which is good.
All right. Henrietta asked, I was told at one time, many years past, that I had diverticulosis. My last colonoscopy, I was not informed that diverticulosis was still present. If you have diverticulosis, can that lead to colon cancer?
Great question.
Lead to colon cancer?
Great question. The answer is no. Diverticulosis is sort of an outpouching of the colon. I tell people it's like if you have one of those tires and you see a weak spot in it that bulges out, that's kind of what diverticulosis is. Unfortunately, it's very common in Americans with our diet. It can lead to bleeding, it can lead to pain and infection, but it doesn't put you at an increased risk necessarily of colon cancer. So that's a great question. Diverticulosis is something that we see all of the time, and thankfully it doesn't put you at a big risk for colon cancer.
All right, I know I saw a few more hands. Don't be shy. We've still got a few more minutes here. Looking forward to answering your questions. Please type them in the chat box or the Q&A box. Henrietta wanted to thank you for answering her 2 questions. No problem.
Oh yeah, no, not at all. That's what we're here for.
If you have a few more, feel free to add those as well. We just want to make sure that everyone leaves very informed and ready to get their next colonoscopy. All right, we got another. This is from Mike. At 65, having no test, is Cologuard worth it? Good question, Mike.
That is a great question. I'm going to be 100% honest with you, Mike. I have a very strong bias against Cologuard. I kind of listed the reasons why earlier. I think if you're going to undergo a test, I think the colonoscopy is the best bang for your buck, because not only can it find colon cancer, it does a better job than Cologuard of finding polyps and advanced polyps that theoretically could turn into a colon cancer. And what it definitely does better than Cologuard is it also treats them. So if your Cologuard was positive, you're still going to end up needing the colonoscopy. So if you're 65 and haven't been screened before, I would certainly recommend, my bias would be to do a colonoscopy, because there's a chance that it's normal, and then great, you don't have to have anything for 10 years. If your Cologuard's normal, you still need another one at 68. So you're not getting a benefit there. If your colonoscopy is abnormal and we find a polyp, well, great, we remove it right there and we're done. If your Cologuard's abnormal, well, you still need your colonoscopy. So I think, what I recommend for all my patients, what I recommend for my parents, my brother, my sister is colonoscopy. I just think that Cologuard has use in a very limited number of patients. But all in all, I would certainly prefer colonoscopy. And when I'm of screening age, I'm doing a colonoscopy. I won't do the Cologuard. So I'll tell you that for my own personal bias.
All right. Rayanne said, thank you for all the great information. Thank you, Rayanne, for participating tonight. Thanks. We've got another question. Kathleen asked, what age do you no longer need a colonoscopy?
Kathleen, I am glad you brought that up. That is a great question. So it's changed, and every doctor will say differently. Most screening guidelines stop at age 80. So if you are, let's say you're 78 and you just had a normal colonoscopy, and otherwise I would say, sure, get a colonoscopy in 10 years. Well, I wouldn't do that because they'll be 88. So 80 is generally the year. That being said, I don't think there's a hard and fast cutoff for me personally. I gauge it on the patient, because there are some patients that are 80 years old and have a lot of health conditions and aren't doing so great. And then there are a lot of patients that are 80 years old that are doing spectacularly. So if they're 85 and they're, walking a few miles every day and doing great, well, there's no reason I wouldn't recommend a colonoscopy, especially if they were having symptoms. The reason being is that, we're trying to treat these things. And so I don't want to ignore that just because of age. But if you look at guidelines, it used to be 75, most will say 80. Each society has its own different rules or guidelines.
All right. Mike asked, can you get the test while driving to the hospital or by yourself? I have no one to help.
Mike, that's unfortunately, if you want the colonoscopy, which with any sort of sedation, legally, there has to be someone to pick you up. And the reason being is that, you'll be getting medicines to sedate you, and then, we can't really safely say, hey, we just gave you some medicines to sedate you and knock you out. Now go drive home, because that would be putting not only yourself, but other people on the road at risk. We can work with you to try to find a time that could work, or find somebody that can help you. You can do a colonoscopy with no sedation whatsoever. And I've done that before on some patients that really didn't want any help, and then you can drive home. But that, I probably wouldn't recommend that. I'll be honest. That's a pretty rare instance. It's you want to be sedated.
Sure. Janelle asked, do probiotics truly benefit your gut health? Would they help provide some protection against colon cancer?
Probiotics, it's a tough question. I think they can provide benefits to gut health, especially in people who have been on antibiotics or have suffered from an infection called C. diff or C. difficile. There's not any evidence that they necessarily prevent or decrease your risk of colon cancer, but there's also certainly no evidence that they hurt. So if you find a benefit from using them, then by all means, I would use them.
Sure. We still got a few more minutes, guys. Do you have any more questions?
I see one from Miss Nelson, Wanda Ocasio-Nelson. And she said they found 7 precancerous polyps in my brother last month in his colonoscopy. How often should he have the next colon? Well, that's a good question. It kind of depends on how big they were, what they looked like under the microscope. If those were normal polyps, I would probably put him at 3 years, but I would have to leave that to his physician who did the colonoscopy, who actually was able to look at it under the microscope. But 7 is a decent number of polyps, so I'd probably keep a closer eye on him.
All right. And Henrietta says, my mom died with colon cancer at the age of 82. I thank you for this webinar. I try to be in tune to my body because, as you stated, it was hereditary. I have lazy bowel movements, but it all contributes to my underactive thyroid. Yeah,
well, I'm sorry to hear about your mother, but and I'm glad that you're present and that you're here to kind of learn. And I certainly, advocate for keeping on track of screening and paying attention to your body and making sure that nothing gets missed. So I appreciate you being here.
Mike also said, thank you for the advice.
No problem. Thank you.
Still got a few more minutes, guys. Let us know if you have any more questions. All right. Nicole asked, can you, what is the difference between Sup Prep and Miralax for PrEP?
So Miralax is an over-the-counter gentle laxative that we use as a PrEP. Suprep is a prescription. Suprep is a little less volume. They just work a little differently in how they clear out the colon. It's it's sort of a physician preference and kind of how the patient tolerates. I personally like Miralax because we give it with Gatorade, and I think most people can tolerate the Gatorade a little bit better than the taste of the Suprep. But both will clean you out.
All right. Anyone else? Do we have any more questions before we conclude the presentation? All right. You're welcome. Someone said, thanks, it's been informative as well as reminders of service rented at Franciscan.
Oh, well, good. Well, thanks for being available.
Mm-hmm. Thank you, Wanda. We're glad you tuned in. Thank you.
Thanks.
She said it's a great presentation.
Thank you.
We just have another question. Mike asked, do you operate out of Olympia Fields Hospital?
I don't. Personally, I don't. I operate out of St. Francis South in Greenwood or Indianapolis campus and at Mooresville. But if you called our office, we certainly could get you in touch with somebody that does work at Olympia Fields if that's what works for you.
Mm-hmm. Well, thank you so much to our clinical expert, Dr. Evan Fitz, for sharing with us this evening. And thank you to all of our attendees for participating in the Colorectal Cancer Prevention and Early Detection webinar. We know your time is valuable, and we're glad you prioritized your health today. Once again, we will send you an email with the recording of this session. Feel free to share it with others who may also find it helpful. You will also receive a survey and supporting documents related to the webinar and its content. Your feedback will help us make future webinars better, so please take a few moments to fill that out. Thanks again for being with us, and have a blessed evening.
Thanks. There's one last question I want to answer for Mark Zur. I think I just saw how soon follow-up colonoscopy. The answer is I don't know exactly because I wouldn't see the polyps, but certainly if it was 6 years ago, I would say at a minimum 5 years. So you should be eligible for a follow-up colonoscopy.
All right, thank you,
All
Dr. Fitz. No, I appreciate that. That trickled in kind of last second. We appreciate it, Mark.
No problem. Thank you.